Hi, Mark Brezinski again. This is a part of the OCT tutorial series, and some of the lectures just have to deal with people who are in the training or early in their career stage, and so this is one of them. Um, and it deals with the fact that um, you need hypothesis driven engineering for the most part. So, OCT and non transparent tissue moved quickly in its first decade because the research was hypothesis driven. And this is just going to be a shorter tutorial of a longer one on how imaging in non transparent tissue was achieved, the various obstacles that were overcome. So I'm Mark Brzezinski. I put these over up relevant to the talk. I put down the things that are relevant to the talk, and it's what you would do on an NIH grant. We're gonna do a little bit of NIH grant. Um, Look at a grant proposal to illustrate the point of hypothesis driven. But I was involved in research, hypothesis driven research, long before OCT, so 1984, and I had been trained by PhDs who were not had nothing to do with engineering, both postdoc and my PhD, and worked with multiple Nobel laureates, and I've been on over 80 grant review committees, and not just the NIH, but Department of Energy, NSF, and and committees for foreign countries, and so it's this hypothesis-driven principle is really critical in terms of getting your work forward, and I'm going to illustrate it. Um, I just wanted to point out that I entered OCT looking for a solution to a problem. And OCT was not developed in non transparent tissue, but we needed to um, be able to image plaque. And I'll go into that in a second. But prior to OCT, had already succeeded in doing HPLC and mass spec and hypothesis driven work. And this work from PNAS is just an example of looking at an off signal for neutrophils. So much of the reason for our success and the reason for the numerous NIH grants is uh, not just hypothesis driven basic science, but hypothesis driven engineering. Technology doesn't drive clinical applications, and this is a hard concept, and I'm sure it makes some people unhappy when I say that. Um, Clinical need and proof through hypothesis driven research are required to push research forward. And like I got a really demoralizing call a few years ago where somebody who'd been working with on OCT really early and had been in the commercial end of it for a significant period of time. Finally, that had ended. And when I talked to him on the phone, they had said to me, as they were no longer in the industry, there just has to be something we engineer that can, the people will accept it and it'll become a clinical utility. And that's not the way it works. I mean, you need double-blind clinical trials and basic studies. You can't just point at a slide and say those are macrophages. You've got to prove it through good science, and so um, uh, that that's discouraging that isn't understood. Now, I took this from a grant. It's an older grant, but it scored a 1 or 2 percentile. But I've modified it a little bit to illustrate a point with it. So when we're thinking in terms of the scientific method, first we have to identify the problem, and this needs to. So I'm going to say this as a grant reviewer, my opinion, and somebody who has written a lot of successfully funded grants. So you state the problem. Acute coronary syndromes like MI are the leading cause of death in the industrialized world. And then we need an unmet need. Current imaging modalities cannot identify the plaques which lead to ACS. Now, there's actually a problem in that jump. And I'm going to, there's multiple problems on this slide, and we're going to come back to it. I'm going to try to use it to illustrate hypothesis-driven work. So, addressing the unmet need. The long-term objective of this work is to develop a new method of high-resolution imaging to overcome current limitations in cardiac diagnostics, principally the identification of coronary lesions to undergo rupture, or that could even be better with it if it said ACS. And this, in my experience, if you don't have something like this in the first paragraph, at the end of the first paragraph, and a high percentage of grants don't, it's very hard to get funded. The end of the first paragraph has to link to morbidity and mortality. So you see these grants that are just going to say, and end with the first paragraph, and we will build, or they're going to use something, and it could be not even engineering, it could be an enzyme pathway, but it doesn't link to, except that sometimes in very global ways, and this is going to be very useful in cardiology and oncology. Well, that's not really linking to morbidity and mortality. And you see these grants, and they represent a high percentage of the grants, which in my opinion are already rejected at that point, or pretty hard to come back from. And you think of all the work people did on it, and the first paragraph has sort of killed the grant. Now, the hypothesis of this work is that several advances could substantially improve the ability of OCT to characterize unstable plaque and improve plaque risk stratification. Okay, I wrote that sentence with an error in it, and I don't know if people pick it up. And these are, again, my opinions. This is not a grant writing course, so I'm just trying to get across thinking the scientific method. So I put down aims, but not all of them are good aims. Increase the axial resolution to 3 microns from 15 microns. Develop dual channel PS-OCT to replace single channel PS-OCT. Develop an OCT imaging guide wire to pass interventional catheters over. Develop dual wavelength absorption spectroscopy for more effective identification of necrotic cores, and reduce multiple scattering with ultrasound. So the problem in the rationale was you need to defend the need for imaging in the first place. So are there diseases where we don't need to image the tissue? Could we treat ACS without ever looking at the plaque? Absolutely. So if let's say Graves' disease, hyperthyroidism, do we actually need to look at the tissue of the thyroid to treat Graves' disease? No. So we have to defend it, whether it's plaque-specific intervention we need imaging for, or to risk stratify patients, in which case you have to say who you're going to stick a catheter down their coronary arteries, because you're not going to do it to everybody in the population, or to understand the pathophysiology. But there was a missing point in the rationale there that would potentially kill a grant. And so now if we go down to the hypothesis, I had added an extra portion to the hypothesis and improve patient risk stratification. So your aims are supposed to prove your hypothesis. So at the end of these specific aims, you're not going to be able to tell if it improves patient risk stratification. So that's a long-term goal. It's not a hypothesis of this proposal. So the fact that we can characterize plaque better, yeah, these things, we can make the justification that they do that, but they're not going to tell us anything about risk stratifying patient. That requires, prospective clinical trials. So let's look at these specific aims. Do they test the hypothesis, and do limitations arise? Okay, I get tortured by have through the years increased the axolution to 3 microns. Do you have any reason to believe that you need to increase the resolution? But there's so much with the students who want to or postdocs, well, we can increase the resolution, we can increase the resolution. Well, there's a lot of problems associated with increasing the resolution. So is there a reason that we can justify increasing the resolution? And I don't actually see why. Is there a reason to go from dual channel to single channel PS-OCT? I am unaware of it. Any strong argument for it? It's covered in the PS-OCT lecture, and I mean, I think that we get all the information we need from dual channel, and it's associated, and in both AIM-1 and AIM-2, achieving these are going to give us increased limitations or problems with the technology that, or make them more error prone. Now, development of an imaging guide wire to pass the catheters over, that would be great. I don't understand why we started this 20 years ago, and then it doesn't seem, I'm unaware of it moving forward. But if you can keep the guide wire with its imaging system in place and path interventional devices over it, then that's a huge advance. And in the field, developing dual wavelength absorption spectroscopy for more effective identification of necrotic cores. Well, I mean, I've discussed why I don't think the diffuse border criteria identifies necrotic cores and whatever a lipid plaque is. I mean, lots of different types of plaques are lipid plaques, so I don't avoid that term. Now, I put down dual wavelength absorption spectroscopy. We actually tested this in early 2000s, and there are better approaches, but for the sake of here, it illustrates the point. And it was part of the this original grant. And reduce multiple scattering with ultrasound. Combine and engineer an ultrasound beam without measuring the ultrasound back, just no receiving, just transmitting, to reduce multiple scattering. So there's only a few ways we know of that you can improve penetration, but imaging penetration, but multiple scattering reduction is one of them. So that's a pretty viable hypothesis that will or aim to improve, to test this hypothesis. So in my opinion, AIMS 3, 4, and 5 test the hypothesis. AIMS 1 and 2 are engineering for the sake of engineering, and they don't really test the hypothesis. So OCT and imaging in transparent tissue, it took a long time. Was that because it wasn't hypothesis driven? Possibly. It also paralleled the development of telecommunication. It's not accidental. And so maybe it just needed the development of, not all the technology was available. But I mean, you look back and you can say it started in 1971, or maybe some people will say it started a little bit later. And it originally was called LCI or OLCR or OCDR, which were the A-scan or one-dimensional equivalents, and then it became OCT. And then in 1991, a paper was published by the Fujimoto group, which did change the name, but also did it in 2 dimensions. But I don't believe this was their paper, where they actually, the left is the retina, but I don't see any layers in there. I don't think this has reached a point where you've tested the hypothesis successfully. And when you look at non-scattering tissue on the right, that looks like, to me, one of these infrared screens of the universe. It doesn't show me anything within the tissue. And this isn't meant as a criticism. It's an important advance. Though the name optical coherence tomography, it isn't optical, it isn't coherent, it isn't tomography. And the authors were aware of that. They just thought it was a good name, and this is not unusual in medicine to where the name doesn't actually match what you're doing. But this is the paper by the same team. And to me, this paper, you actually saw the layers of the retina. And so cardiology work was already ongoing at this time. It started around 1993. We had started it. uh, which was more morbidity and mortality driven. But in this particular paper, they didn't need to match on a micron scale histology with the OCT images because the retina has well-defined layers, and you can test the hypothesis successfully without it. But once you get into pathology, and you're starting to say you're seeing things like macrophages, then you've really got to match them on a micron scale. So OCT imaging in non-transparent tissue. There were engineering things that needed to be overcome. And there were a lot of things you could engineer, but they weren't needed. So there were very specific issues. First, the penetration was only 200 microns if you used the ophthalmology system in tissue, which wasn't good enough. If you did not beat that and get to the roughly 3 millimeters, then OCT would be useless in coronaries and any other tissue. It needed to be at video rate for the coronary artery and in a lot of other applications, and it took us like 30 seconds per image. So that needed to be overcome, and the faster the acquisition rate, you needed to increase the power of the sources. There was a lot of question. There was a lot of, the majority of the field didn't believe that OCT could be done in non-transparent tissue, but also we didn't know this could ever be done through a catheter, and this is explained in another slide, that 9 micron core, but also coupling 9 micron cores in the cath lab, could that be achieved? That's an important engineering question and needed to be addressed. Increasing the dynamic range, which is critical for penetration and contrast. I put in micron scale matching of histopathology, which I don't know if you call that engineering or not. It does actually. We had to engineer the way we were doing it, but and we need resolutions about 10 to 20 microns. So if it wasn't for this slide wasn't done by our group. It was done by a different group, but I had seen it. So this was part of the quest to go after non-transparent tissue. So I was in another, the problem was we didn't have a technology to visualize vulnerable plaque. And OCT seemed to have a possibility, but the green line shows absorption and scattering with an ophthalmologic system. And if it wasn't for this slide, I would have never gone into this field. And if the only thing available was the ophthalmologic system, OCT never would have shown any feasibility in cardiology. But the red line showed an optical window. So scattering and absorption were low, which predicted penetrations. The kind of penetrations we needed were possible. And so this is the reason, this concept of pursuing a technology to answer a problem is not uncommon. So, the most famous example is Watson and Crick pursuing X-ray crystallography for to get the structure of DNA. Here, this is a pursuit, trying to figure out what technology will actually allow us to see vulnerable plaque, and that's what this whole was all about. And so, a lot of things needed to be accomplished. You can't just engineer in isolation. Besides being hypothesis driven, we talked about matching. You needed the supplies, yes, but we needed things like zebrafish tanks and tadpoles as you were increasing acquisition rates or changing resolution. The beating hearts of the tadpoles were useful in terms of monitoring acquisition rates. You needed to be able to do animal studies as minimal as possible. I hate animal studies. The laser technology, PIs with cross training, an incredibly talented group, and this was done by a lot of talented people. And I go back to the fact that was from a previous lecture, but we just didn't bring in clinical trial experts early enough, and the field paid for it. So this was the paper that showed OCT could image in non-transparent tissue. It was a scientific paper. If you go through, it tests the hypothesis. 2 papers were published with images we did not use in this paper that managed to come out early because the circulation paper was hypothesis driven. It took about 2 years to get published, whereas the Nature and Medicine paper, that's just, it was somewhat of a review, or it was just pictures. And the same thing with the American Journal of Cardiology paper. It was just images in cardiology, so those didn't test a hypothesis. So it seems funny that we jumped from showing it in non-transparent tissue to in vivo the next year, but it had taken since 1993 to 1996 to achieve it and then get it published, and then work was going on to develop the system for in vivo imaging, which was achieved in 1997 in Science. So let's pick a more current topic. We can engineer for macrophages, necrotic cores, plaque healing, or evidence for dual channel PS-OCT, but let's just go with plaque healing. So we published a series of papers in this decade. The first one was in 1994 or 2014, where we started to think, the question had been asked, it wasn't only 15% of thin caps lead to ACS, and a majority of them from the prospect study actually just get thicker. So what's special about the 15 to 18% or 18% that progress to acute coronary syndromes? Well, in 2014, we linked them to long cores, not necessarily from the right reasons, as was pointed out by the Washington group and Mount Sinai group, but we were confident axially long cores were the key. And then in JAMA cardiology, we linked that long cores were associated with poor healing. And then finally in circulation in 2019, that blood vessels couldn't get to the area with long cores, and that was the reason why it was healing poorly. And we're going to engineer to this, and I'll get to the engineering point in a minute. So there were paradigm shifts in this process. First was that acute coronary syndromes were linked to long cores, and that I believe I coined the phrase in that JAMA cardiology paper, acute coronary syndromes were a double hit of plaque rupture and impaired healing. And I don't believe that was published anywhere else before then. And then in the first one was a paradigm shift, clearly, because it went absolutely against current paradigms. And angiogenesis, to the point of the circulation paper, was felt to be detrimental. It was supposed to be bad. And their 2019 circulation paper, I'm unaware of another one that says that it was critical in healing and it was needed. And contrary to what some people publish about plaque healing, the current therapeutics, it's highly questionable, can work if you don't have cellularity and you don't have vasculature in the area that ruptures. So, and some people have tried to link our conclusions to these quote plaque healing in vivo OCT studies, and they played a minimal role. So the Mann and Davies paper were very important. Our own histologies in that in vivo paper of ours played a role. Going back and looking at the Berger papers, and particularly the 2019, or the New England Journal of Medicine paper in 1984, some injection of contrast into vessels under pressure with OCT and then imaging the wall. The prospect trial, and unfortunately, IVUS played more of a role in our conclusions than OCT did, which is painful to me. The in vivo OCT studies told us, confirmed, and I'm going to show it on the next slide, long cores were associated with ACS. This is how we read it. Not that these studies were going after that hypothesis, and not that we knew that they were necrotic cores, but this long core concept we could see in tables in the in vivo studies. Now then, this work by Ritterma, that it takes days after a rupture for a clot to occlude the vessel, and the paper by Gary that showed that if you have time for smooth muscles and endothelial cells, if they're in the area, to get in a clot and stabilize it were critical. And I'm citing a review that till 1980, we feel we've turned over several paradigms in that paper, but in terms of overall the state of the field, this is a great review. I know Vermani and Falk, and they're superb in this field. Now, people link that our conclusions to these papers, and from these papers, the only thing that I got personally was that if you looked at their cores, two of them have to deal with, quote, healing, and I'm going to question whether if they're looking at healing or not, or whether you can say that confidently. And two of them didn't, the two on the bottom. But on the top paper, these healing papers, to my read, the first paper says patients with healing you have to treat them more aggressively with their, quote, healed plaques. And then the second one, it says that in the second paper that healed plaques, I believe the conclusion was, are at lower risk for ACS and needed to be treated less aggressively. But what was consistent, and this is from databases, retrospective data, it's not prospective at all. It was from databases. And what was consistent in it was the patients with angiographic, more severe disease had more ACS. And so, in both papers, more angiographically more severe coronary artery disease was associated with ACS. I don't think that's anything new. And then if you understand whether or not you're looking at healing plaques, I don't know how you can link the morbidity and mortality data to anything but the angiographically more severe disease. But I recommend that this is my read on these papers. I recommend people read them for themselves and don't just read abstracts and the end of the papers, look at the papers. But it was from the tables of these, including these 4 papers, where they looked at plaque length, core length, and core volume. We saw that this concept that long cores are bad seemed to be confirmed. And that's what I really got out of these papers. Maybe somebody else got something else, but that's what I got out of it. And so here, here's an example of a core that's 40 millimeters long. And this thing is going to be dangerous as it extends from the left main down the coronary. And core composition, I've already said I don't believe in the diffuse border criteria for identifying necrotic cores. So a core that's very long has varying composition, and it can all be lipid, quote, lipid core. It could be PIT, which is lipid. It could be xanthomas, which is lipid. It could be true necrosis, early necrosis, late necrosis. The left shows late necrosis. And this plaque on the bottom with trichrome shows the various stages. So if we go to the paper that says um, that, and I think it's of great people are going in with OCT and looking for healing, and I'm not trying to be critical of those groups or the people who did this work. And this particular paper is the one paper that's supposed to validate OCT imaging, looks at healed plaque. And healing, type 3 collagen was a healing plaque, and type 1 collagen was more stable area. And this group nicely did histopathology matching first, and they did do picroserous staining, which is critical, but it was, if to my read, only 18 autopsies from 18 autopsies, and that's for the amount of clinical in vivo studies that are being done stating that they're seeing healing. That's a small number. And so the concept is that if you see multiple heterogeneous layers, and you can read on the bottom the quote from their paper, and I guess I should read, the corresponding OCT images exhibit one or more homogeneous signal-rich layers of different optical signal located close to the luminal surface with well demarcated from the underlying tissue, which is deemed OCT derived healing plaque, HCP. And so we are going to get to engineering this, and to engineering to solve this problem. But here is one of my issues with that, besides the sample size and the potential that severely diseased, we said in the two papers, the ones that had ACS had severely diseased coronaries by angiography. Well, it's hard to find healing within all that disease anyway. That plaque I showed was a brick. But here's a paper from 2006 where we looked at collagen type 1 sponges, but in different media. So you can see in saline, you see the layers, and in lipid, the same sponges, the layers become invisible. So you can have the same amount of collagen type 1, but if the medium is different, then the layers are different. So that doesn't necessarily test your hypothesis. So can we engineer our way specifically to our hypothesis, which is looking for plaques that have more collagen type 3, and start looking if this is associated with healing? Well, this goes back again to that paper and numerous other papers we had published in the first decade of the millennium. But in spite of the fact the back reflection intensity changed with the medium, it was still birefringent, the collagen type 1. So you can use polarization sensitive OCT. And we did do that with, and it's not limited to time domain. So here we put polarization paddles, and the schematic shows a time domain system. And this is a motorized polarization paddles bit. You just need polarization paddles. And we had shown back in 2005 or 2006 that if we just look at the picroceros on the right, the red arrow shows collagen type 1, the green arrow shows collagen type 3, and they have different birefringence. And so if I were to do the study, I would, and we have put the polarization paddles here were put on a light lab system, and we've put them on Thor lab systems. And so if I were to do the study, I would do it with engineer the system, which is not sophisticated engineering, to do polarization sensitive imaging to look for these, quote, healing plaques. And the sheer fact that there are layers can just be differences between lipid and water-based or just pure collagen, like a tendon type configuration. So the point I was trying to get across is that the field, I don't see how clinical fields can move forward quickly without hypothesis-driven engineering and research. And this includes both basic research and clinical trials and prospective clinical trials. And the OCT field is in desperate need of both. So thank you very much.